Welcome back to the deep dive, where we cut through the information overload to bring you the most essential insights. Today, we've got a truly focused mission tailored specifically for you, a surgical pathologist who's just wrapped up a bone and soft tissue fellowship, and you're now gearing up to sign out cases independently. This deep dive isn't just a review, it's designed to be your, let's say, rapid fire yet comprehensive guide to a truly fascinating and often challenging group of lesions: fibroblastic and myofibroblastic tumors. We're talking about a whole spectrum here, from the truly benign to the locally aggressive, all the way to outright malignant entities. Each one has its own unique set of clinical presentations, microscopic appearances, and, well, increasingly genetic signatures. And these signatures are absolute game changers for diagnosis and, importantly, patient management. Our goal today is to arm you with the confidence to differentiate these entities, understand their crucial nuances, and feel fully prepared as you step into independent practice.
Indeed. This field really demands a keen eye for subtle distinctions and, frankly, a solid grasp of the underlying biology. What's truly fascinating, I think, is how seemingly similar spindle cell lesions under the microscope can have vastly different implications for the patient, completely different outcomes. We'll be connecting the dots today, emphasizing those aha moments that make a real difference in your diagnostic approach, and providing the context that helps you understand not just what to look for, but why it matters for clinical management. The practical side.
So as you're preparing for independent sign-out, what's maybe a common pitfall or a particular challenge that stands out to you when you think about these specific tumors? Is it the morphological overlap, or maybe the often alarming rapid growth, or perhaps the ever-evolving molecular landscape?
It's often a mix of all three, honestly. The overlap can be tough. Clinically, they can present alarmingly, and keeping up with the molecular is key.
Right. Today, we're diving deep into some key examples to sort of navigate those challenges and arm you with that crucial knowledge. Let's unpack this material and get you ready. Okay, let's start with some of the more common fibroblastic and myofibroblastic lesions, the ones that are often benign, self-limiting even, but can be real diagnostic mimics. We'll kick off with nodular fasciitis, a classic example that, well, every pathologist needs to master, especially because it can sometimes throw you for a loop clinically. So, nodular fasciitis, it's a self-limited mesenchymal neoplasm. Now, that key word here for your independent sign-out is self-limited. It often resolves on its own, which is kind of amazing. It typically pops up in the subcutaneous tissue. What makes it unique under the microscope is its composition, these plump, uniform fibroblastic and myofibroblastic cells. But the real game changer in its definition, the molecular insight that has truly cemented its nature, is the consistent presence of a USP6 gene rearrangement in most cases.
Exactly. Before that discovery, there was a lot of debate, wasn't there? Was it reactive or was it truly neoplastic?
Right. USP6 pretty much proved its clonal nature.
Clinically, nodular fasciitis can be quite a surprise. Patients often report, well, alarmingly rapid growth. The lesion appears and enlarges quickly, typically over just maybe 2 to 3 months. This rapid onset can understandably raise concerns, for both patients and clinicians. It often prompts urgent biopsies because they're worried about something more aggressive.
Makes sense. Fast growth usually equals scary in people's minds.
Totally. But the lesions themselves are usually small, generally under 2 centimeters, almost always less than 5. Patients might feel some soreness, maybe tenderness, and while it can technically be anywhere, you'll most frequently see it on the upper extremities, the trunk, and the head and neck area.
Okay, and where exactly does it sit?
Topographically, it usually sits right on the surface of the fascia, often extending up into the subcutis. On imaging, though, it's pretty non-distinctive, which again highlights why your histological and molecular findings are really paramount. And epidemiologically, nodular fasciitis is relatively common, especially in young adults. Affects males and females pretty much equally. Now, what's truly fascinating about its pathogenesis and the molecular insights is how the identification of those recurrent USP6 gene rearrangements, particularly involving promoter swapping mechanisms with partners like MYH9, how that firmly established its clonal neoplastic nature.
Right, because for years, people debated its true identity.
Exactly. But here's the aha moment for you, especially as you start signing out. Despite being a bona fide neoplasm with a clonal genetic abnormality, it's consistently self-limited and often regresses. This has led some researchers to use that really intriguing term, transient neoplasia.
Transient neoplasia, I like that.
It's a critical concept for your independent practice. A clonal genetic abnormality does not automatically equate to aggressive behavior. You're giving patients and clinicians some much-needed reassurance based on this, more nuanced understanding.
That's such a crucial point. It really does reshape our understanding of what a neoplasm can actually be. And it gets even more interesting, right? Because USP6 rearrangements aren't exclusive to nodular fasciitis.
That's right. They're also found in other benign conditions, things like aneurysmal bone cyst, myositis ossificans, cellular fibroma of tendon sheath, and even fibro-osseous pseudotumor of digits.
Wow. So that shared genetic link explains why these seemingly diverse entities can sometimes share similar histological features.
Precisely. It points to a common underlying biological thread. It's quite elegant, really.
Okay, let's unpack its histology then, because this is where that famous tissue culture look really comes to life under the microscope, and it's one of your most important diagnostic clues, right?
Absolutely. It's very distinctive.
So you'll see these plump, spindle-shaped cells, and critically, they lack significant nuclear hyperchromasia or pleomorphism. That's key.
Very key. They look active, but not malignant.
Mitotic figures. They can be plentiful, even numerous, sometimes worryingly so, but here's your key differentiator. Atypical forms are not observed.
Exactly. You don't see those bizarre multipolar mitoses you'd worry about in a sarcoma.
Paramount for ruling out malignancy. The overall pattern is highly cellular, but often partly discohesive and quite myxoid, giving it that torn, feathery, or classic tissue culture-like character, almost like cells just growing freely in a petri dish.
Yeah, that's a great description. In denser areas, you might see sort of S-shaped, C-shaped fascicles, maybe even a storiform pattern, but it's often looser than that.
And the stroma.
Normally little collagen, but you can get focal increases, sometimes even keloidal-looking collagen bundles. Microcystic stromal changes are also very characteristic, little tiny holes in the background. You'll also frequently find associated features like extravasated red blood cells, lots of little RBCs floating around, plus lymphocytes, and sometimes osteoclast-like giant cells. These can sometimes give it a very reactive appearance, honestly, adding to the diagnostic challenge.
Right, makes it look inflamed or something.
Exactly. And the border of the lesion is often infiltrative, at least focally, even if it seems well delineated grossly. You'll typically see peripheral extension between fat cells or muscle cells. It's not usually a perfectly round ball.
Okay. What about stains, IHC?
Immunohistochemically, the neoplastic cells typically express SMA and MSA in that characteristic myofibroblastic tram track pattern along the cell borders. Desmond positivity is sometimes seen, but usually just focal.
And the molecular testing, you mentioned USP6. Necessary.
Usually unnecessary in classic cases, when clinical and histological picture is clear, but it's invaluable in challenging or equivocal cases for confirmation, maybe a small biopsy or unusual location. Break apart USP6, FISH, or even next-generation sequencing are the methods you'd use.
And prognosis.
Excellent. Recurrence after simple excision is rare. This is why knowing it's that transient neoplasia is so vital for patient counseling. You save people from overly aggressive surgery.
That's a fantastic summary of why nodular fasciitis is such a quintessential entity to master early on. Building on that theme of related lesions, especially ossifying ones, let's talk about myositis ossificans and fibroosseous pseudotumor of digits. These are truly ossifying mimics, aren't they? Myositis ossificans and fibroosseous pseudotumor, or FP, of digits. They're also self-limited benign neoplasms, composed of spindle cells and obviously osteoblast-making bone. And interestingly, myositis ossificans, FP, and even soft tissue aneurysmal bone cyst are now recognized as belonging to the same sort of neoplastic spectrum.
Right, often sharing those USP6 rearrangements we just discussed.
So that genetic link helps us understand why they can have overlapping features and why they behave in a similarly benign fashion.
Clinically, these lesions also often exhibit rapid growth initially. And their features, both clinical and radiological, tend to evolve over time, which is a really important point. Early on, maybe the first week or two, patients experience swelling and pain, looks inflammatory. But the key is in the progression. Within weeks, maybe 2 to 6 weeks, you start to see that flocculent mineralization appearing at the periphery on imaging. And that evolves into that characteristic eggshell-like layer of bone, with the center remaining relatively radiolucent.
The zonation phenomenon.
Exactly. Where the bone matures from the periphery inwards, or is most mature at the periphery. This is your crucial diagnostic hallmark under the microscope too, distinguishing it from something like a true osteosarcoma, which typically ossifies differently, often centrally.
Got it. So histologically.
Histologically, you'll see hypercellular fascicles of pretty uniform spindle cells admixed with woven bone that displays this clear zonation pattern, most mature bone at the edge.
And USP6 testing here.
It can be useful for confirmation in the right clinical pathological context, perhaps an unusual presentation. But honestly, that zonation is often your primary visual cue. It's pretty striking when you see it.
And the prognosis.
Excellent prognosis for both, with simple excision. Recurrence is uncommon.
So for both nodular fasciitis and myositis ossificans, that rapid growth can certainly be alarming for patients and clinicians alike. But understanding their self-limiting nature, knowing their molecular drivers like USP6, that's absolutely key to making an accurate diagnosis. And, importantly, providing appropriate reassurance during your independent sign-out. You're preventing unnecessary anxiety and potentially overly aggressive treatment. Okay, now let's shift gears slightly to other benign entities that have their own distinctive patterns or specific anatomical predilections.
Right. Moving on, we encounter other benign fibroblastic and myofibroblastic lesions. But these are often defined more by, say, unique cellular characteristics, very specific anatomical preferences, or distinct genetic signatures sometimes. Recognizing these nuances is really what guides us away from making broad, less specific diagnoses and towards a more precise classification.
Okay, let's first talk about proliferative fasciitis and proliferative myositis. These are fascinating because they share a really unique cellular characteristic, the presence of these large, quite prominent ganglion-like cells.
Exactly. Those big cells really stand out.
So proliferative fasciitis is a mass-forming subcutaneous proliferation.
Right, typically in the fascia or subcutis.
Well, proliferative myositis has the same cellular composition, but, as the name suggests, occurs within skeletal muscle itself.
Clinically, both can present with that familiar rapid growth, similar to nodular fasciitis, which often leads to swift excision and, again, can initially raise alarm bells.
Sure.
However, unlike nodular fasciitis, a recurrent genomic abnormality or specific translocation hasn't yet been firmly established for these entities. They seem genetically distinct.
Okay, so what's the aha moment here for diagnosis?
For you, it's those distinctive large ganglion-like cells. They usually have quite prominent nucleoli, too. They're the defining feature mixed in with a more bland myofibroblastic proliferation. In proliferative myositis specifically, you'll also often see an intramuscular checkerboard growth pattern. The tumor cells kind of grow between the muscle fibers, infiltrating in that pattern.
And the prognosis.
Excellent for both. They rarely recur after conservative local excision, and importantly, they do not metastasize. So your key here is really recognizing those distinctive ganglion-like cells in the right setting.
Okay. Next, we have inclusion body fibromatosis, which I always think of as the digital children's tumor because of its strong predilection.
That's a good way to remember it. Very characteristic location and age group.
It's a benign myofibroblastic tumor with these really characteristic eosinophilic intracytoplasmic inclusions, and it does have some potential for local recurrence. Its localization is quite classic, isn't it? It involves the dorsal or dorsolateral aspects of the second, third, and fourth digits.
Usually the fingers, less often the toes.
Often sparing the thumb or big toe, and the hand and foot itself. These are typically asymptomatic, dome-shaped skin nodules.
Epidemiologically, it's rare. Almost exclusively seen in children under 5 years old, with many cases actually being congenital, present at birth. While its underlying pathogenesis remains unknown, for your diagnostic purposes, those bright pink eosinophilic intracytoplasmic and paranuclear inclusions are pretty much pathognomonic. You see abundant plump spindle cells in the background, yes, but the inclusions are what truly clinch the diagnosis.
And despite the potential for local recurrence, it's a benign entity overall.
Correct. Benign behavior. Recurrence is managed with re-excision.
Okay, moving from the very young, let's consider fibroma of tendon sheath. This is a benign fibroblastic, myofibroblastic nodular proliferation, usually attached to a tendon or its sheath, very commonly on the finger tendons.
Right. Thumb, index, middle finger are common spots.
Your key visual on histology will be these bland spindle cells swimming in a pretty collagenous background, and often with characteristic slit-like, thin-walled vessels. That's a helpful feature.
Yeah, those vessels can be quite striking. But here's a potential diagnostic pitfall for you. You can also see degenerative changes sometimes, things like myxoid or cystic areas, even chondroid or osseous metaplasia, and sometimes you see bizarre pleomorphic-looking cells scattered within it.
Ah, that sounds like it could be worrying if you weren't expecting it.
Exactly. It can be a trap for the unwary pathologist. But it's crucial to remember that these are just degenerative changes and not indicative of malignancy. The overall well-circumscribed nature and the bland background cellularity are your guides. Prognosis is excellent. Simple excision is curative.
And speaking of connections and potential pitfalls, let's dive into desmoplastic fibroblastomas, myofibroblastomas, and the fascinating 13q-RB1 family of tumors. This group really underscores how much our understanding has advanced with molecular insights, grouping things together we didn't realize were related.
Absolutely. Let's start with desmoplastic fibroblastomas. They are rare, predominantly affect adults, maybe median age 50s, 60s. The key insight here, diagnostically, is their recurrent translocation, T211, Q31, Q12. This leads to deregulated FOSL1 expression, and what you see immunohistochemically is diffuse, strong FOSL1 nuclear immunoreactivity. That's a key differentiator against potential lookalikes. Then we have myofibroblastomas. Well, about half are found in the inguinal or groin area, vulva, scrotum, perineum. They actually have a pretty wide anatomical distribution, trunk, breast, extremities.
So location isn't always the key feature.
Not solely, no. For your sign-out, the key IHC findings are diffuse co-expression of desmin and CD34 in most cases, like 90%. And crucially, about 90% also show loss of nuclear RB1 expression by IHC.
Okay, RB1 loss. That rings a bell.
It should, because that leads us directly to cellular angiofibroma. It typically arises in the superficial soft tissues of the vulvovaginal, inguinoscrotal, or peritesticular regions, much more site-specific. And its pathogenesis, defined by partial or complete losses of chromosome 13, which, importantly, includes the RB1 locus.
Ah, so there's the connection. The aha moment here is the concept of the 13q-RB1 family of tumors.
Exactly. The overlapping morphological features, the IHC patterns like CD34 and desmin co-expression sometimes, and crucially, the shared RB1 loss, all support the hypothesis that cellular angiofibroma, mammary and soft tissue, myofibroblastomas, and even spindle cell pleomorphic lipoma are all variations along the spectrum. They're genetically related lesions.
Okay, so for me, recognizing one of these should immediately bring to mind this broader family and its shared molecular characteristic.
Precisely. It guides your differential and your thinking about ancillary tests.
So for cellular angiofibroma specifically, what am I looking for histologically?
Bland spindle cells, often short bundles of delicate collagen fibers between them, and numerous small to medium-sized thick-walled blood vessels. Sometimes adipose tissue mixed in, the pelvic or perineal inguinoscrotal location, and that loss of RB1 by IHC are your key confirmatory clues.
Okay. Next, let's turn to calcifying aponeurotic fibroma, which I like to think of as the recalcitrant calcifier because of its relatively high recurrence rate.
That's a fair nickname. It does tend to come back.
It's a rare neoplasm, most commonly found on the palmar surfaces of the hands and plantar surfaces of the feet. Clinically, you'll see a painless, often poorly circumscribed mass, may be present for a long time. Radiographic calcifications are common, as the name suggests.
What drives this one, interestingly, is a recurrent FN1 EGF gene fusion. That's a relatively recent discovery.
Okay, FN1 EGF, and histologically.
You'll see an infiltrative lesion composed of bland, often evenly spaced spindle cells arranged in parallel fascicles within a collagenous matrix. And characteristically, islands or geographical areas of calcified matrix, often surrounded by palisading epithelioid-looking fibroblasts. That palisading around the calcium is quite typical.
And prognostically, you mentioned a recurrence.
Yes, this tumor has a high local recurrence rate, up to 50%, sometimes years after the initial excision, due to its infiltrative nature. It's hard to get it all out sometimes. This is your key point for patient counseling and surgical planning. Despite recurrence, though, it has limited growth potential. Multiple recurrences are less common. Conservative surgery is usually recommended.
Now let's touch upon an emerging entity relatively new on the scene, the EWSR1 SMAD3 positive fibroblastic tumor, often referred to as the acral fusion, given its strong predilection for the hands and feet.
Right, provisional name still, but defined by that specific fusion.
This is currently considered a benign neoplasm, defined by a fusion of exon 7 of EWSR1 with exon 5 of SMAD3.
Typically small, painless, superficial tumors in those acral sites.
So your takeaway, acral location plus this specific EWSR1 SMAD3 fusion equals benign behavior.
Okay, shifting now to angiofibroma of soft tissue. This entity typically arises in the extremities, primarily the legs, often near or involving large joints like the knee. It's usually a slow-growing, painless mass. The key molecular finding here is the recurrent AHRR-NCOA2 fusion, which is present in about 60–80% of cases.
AHRR-NCOA2. Got it. And the look.
Histologically, look for a variably myxoid or collagenous stroma, quite bland, uniform short spindle cells, and really innumerable small, thin-walled, branching blood vessels. Very vascular.
Prognosis.
It follows a benign course. Rare local recurrences can happen, but no metastatic potential.
Let's discuss neutral-type fibroma next. A rare, benign collagenous lesion usually found in the posterior neck, as the name implies.
So it can occur elsewhere, upper back, face, extremities.
A significant clinical feature, and one you should definitely be aware of, is that up to 50% of patients also have diabetes mellitus. That's a strong association.
It is worth asking about or noting in the clinical history.
Histologically, it's a pretty paucicellular collagenous lesion, often with small nerve bundles entrapped within it, and the spindle cells are bland and CD34 positive.
Benign, but like some others we've mentioned, it can recur locally if not fully excised. Doesn't metastasize. Moving on to acral fibromyxoma, another acral lesion. This is a benign fibroblastic neoplasm with a very marked predilection for the subungual and periungual aspects of the digit, so right around and under the fingernails or toenails. And unlike some others, this one can actually be painful, often causes nail deformity or bone erosion on X-ray.
Okay, so potentially more symptomatic. What's the histology?
You'll see a dermal-based tumor that infiltrates down into the subcutis, often has a lobulated architecture, maybe vague storiform or fascicular growth. The spindle cells are bland, set in a variably metalloid or collagenous matrix.
Any helpful IHC?
Yeah, CD34 positivity is common, and frequent loss of RB1 expression by IHC is also seen. Another member of that potential RB1-related family, perhaps.
And prognosis?
Local recurrences are fairly common, maybe up to 22% or so, but they're non-destructive and cured by re-excision. No metastases reported.
Now let's look at Gardner fibroma. This one has a very important systemic association that you absolutely need to know about. It's usually linked with familial adenomatous polyposis, or FAP.
Crucial connection. Cannot miss this one.
This is a benign plaque-like mass characterized by thick, haphazardly arranged collagen bundles with only sparse fibroblasts scattered within. Its localization commonly involves the superficial and deep soft tissues of the torso back, paraspinal area, or head and neck.
The critical point for your independent practice is its strong association with FAP. Approximately 80% of cases are linked to an APC gene mutation or familial desmoid fibromatosis. This means a diagnosis of Gardner fibroma should always prompt screening for FAP in the patient and potentially their family. It can be the first sign.
Wow. Okay, so the pathology report has major implications beyond just the lesion itself.
Absolutely. Histologically, look for that dominant feature. The haphazard arrangement, of course, collagen fibers. They often have characteristic clefts or cracks within them. Very few inconspicuous spindle cells. And helpful is the entrapment of adjacent adipose tissue and neurovascular bundles at the edge of the lesion.
IHC.
CD34 is almost always positive, SMA is negative, and nuclear accumulation of collecnon is often observed, especially in the FAP-associated cases, linking it path-magenetically to desmoids too.
Finally, in this benign but sometimes tricky category, let's discuss the superficial CD34 positive fibroblastic tumor. This is a truly distinctive low-grade neoplasm of the skin and subcutis, and it's a potential diagnostic pitfall because of its appearance.
Yes, it can look quite worrisome at first glance.
What makes it so interesting and potentially alarming is its morphology. It presents with marked nuclear pleomorphism. These cells can look really bizarre.
They can. Big hyperchromatic nuclei sometimes.
However, and this is the crucial part, despite this aggressive appearance, it has a very low mitotic count. Mitoses are rare. It also shows diffuse CD34 expression and, interestingly, frequent aberrant keratin immunoreactivity.
This tumor really underscores the importance of clinicopathological correlation.
Yeah.
You cannot diagnose based on atypia alone here. You can have something that looks quite aggressive morphologically, like this superficial CD34 positive fibroblastic tumor with its marked pleomorphism. But its clinical behavior and prognosis are incredibly benign. Excellent prognosis, actually. Only a single reported lymph node metastasis ever. Basically, no local recurrences reported in follow-up studies.
So for your independent sign-out, this means relying solely on nuclear atypia can be really misleading.
Absolutely. Always, always integrate the clinical context, patient age, location, it's superficial, growth rate usually slow, with the full immunohistochemical panel. CD34 and keratin positivity are helpful. Knowing the expected genetic landscape for each entity is paramount, as it can often confirm a benign diagnosis despite worrisome morphological features, or, conversely, raise suspicion for something more serious when a bland morphology might be hiding a more aggressive genetic signature. It cuts both ways.
Okay, now let's move into a category that demands a bit more caution. These are lesions that are locally aggressive or have a significant potential for recurrence, even if they rarely metastasize. These are the ones that can truly impact patient management and require careful attention to surgical margins and long-term follow-up. We'll start with the big one, desmoid fibromatosis. Desmoid fibromatosis. It's defined as a locally aggressive but crucially non-metastasizing deep-seated myofibroblastic neoplasm.
That paradox, locally aggressive behavior but benign systemically, is absolutely key for you to grasp. It drives management decisions.
It's characterized by infiltrative growth and a strong propensity for local recurrence if not completely excised. It can be found most commonly in the extremities, but also frequently in the abdominal wall, the retroperitoneum, mesentery, or the chest wall.
Clinically, it generally presents as a painless mass, often deep-seated, and feels fixed on examination because it infiltrates surrounding structures. About 10% of patients might report a history of prior trauma or surgery to the area, and about 15% of abdominal wall desmoids are associated with recent or current pregnancy. Hormonal factors seem to play a role.
And the FAP connection again.
Yes. For MAP patients, these tumors most often present intra-abdominally, frequently after abdominal surgery. On MRI, they typically show mixed signals, reflecting variable cellularity and the amount of dense fibrous stroma. And site-specific complications are crucial to recognize and communicate. Things like intestinal obstruction for intra-abdominal lesions or limb contracture and chronic pain for those in the extremities. Epidemiologically, it's rare overall. Affects young to middle-aged adults typically, slightly more common in women, though equal in kids and older adults. The pathogenesis is absolutely dominated by the WNT-catenin pathway. This is central. The vast majority of sporadic cases, maybe 90–95%, result from specific point mutations in the B-catenin gene itself, CTN and B1, usually at codons 41 or 45.
Okay, specific mutations.
Right, and for desmoids arising in Gardner syndrome, or FAP, they're linked to germline mutations in the ATC tumor suppressor gene instead. But the critical downstream mechanism here is that both types of mutations, CTN and B1 or APC, interfere with the normal degradation of B-catenin protein. This leads to its nuclear accumulation, and that's the driver.
So B-catenin builds up in the nucleus and pushes cell proliferation.
Exactly. It activates the WNT-catenin pathway, promoting cell proliferation and survival, driving the tumor growth.
This atenin pathway is such a fantastic example of a clear molecular driver that completely changes how we understand and approach these tumors. For your diagnostic purposes, I know fine needle aspiration can be tricky, often just showing bland spindle cells.
Very nonspecific on FNA, usually.
Yeah.
Difficult diagnosis cytologically.
So CTNNB1 mutation analysis, that can be immensely helpful in small biopsies, right? Or maybe when the B-catenin immunostain isn't perfectly clean.
Absolutely. It can provide definitive evidence in equivocal situations. And that nuclear catenin staining by IHC, it really is a powerhouse for differentiating desmoid fibromatosis from its mimics. It's usually strong and diffusely positive in the nuclei of the tumor cells. It just highlights how much of a game changer molecular pathology and IHC have become for this field.
And prognostically.
Locally aggressive, as we said, frequent local recurrences, maybe 20–50%, especially with inadequate surgical margins. Getting clear margins is tough due to the infiltrative growth, but remember, ordinary desmoid fibromatosis almost never metastasizes. Rare exceptions exist, but it's the rule. This is a crucial point for counseling clinicians and patients. It helps them manage expectations and make decisions about maybe less aggressive approaches sometimes, like observation or medical therapies, versus always going for radical surgery.
Okay, let's move on to lipofibromatosis next, a distinct entity primarily in pediatric soft tissue tumors.
Right, think kids and infants for this one.
This is a rare but frequently recurring pediatric tumor with a predilection for the hands and feet mostly. It's defined by a really distinctive admixture of three components: mature fat, short fascicles of bland spindle cells, and characteristically, these lipoblast-like cells right at the interface between the spindle cell and fatty components.
Those vacuolated cells at the interface are a key feature to look for. Clinically, it's usually a slow-growing, poorly demarcated subcutaneous mass. It can involve skeletal muscle. Most cases are in young children, birth to maybe early teens, half diagnosed by age 1, and about 20% are actually congenital. Its pathogenesis seems to involve fusions that lead to activation of EGFR or other receptor tyrosine kinases, suggesting the PI3Ka-KDM-TOR pathway might be involved downstream.
And grossly.
Firm, rubbery, poorly demarcated usually. White or yellow uncut surface. Getting clear margins can be difficult because it's infiltrative.
So my key takeaway is pediatric age group, hands-feet location typically, and that unique histological mix of fat, spindle cells, and those interface lipoblast-like cells.
That's it in a nutshell. And remember the recurrence potential.
Now let's explore the continuum between giant cell fibroblastoma and dermatofibrosarcoma protuberans, or DFSP. This relationship is really unified by a specific molecular event. the COL1A1 PDG-FB fusion. This is a crucial molecular relationship for your independent practice to know.
Absolutely.
Yeah.
Let's start with giant cell fibroblastoma, or GCF. It's considered a locally aggressive fibroblastic neoplasm, primarily affecting children, though adults can get it too. It's closely related to DFSP, often considered a juvenile variant or part of the same spectrum, because it shares that same CO1A1 PDGFB fusion gene.
Okay, so what are the key diagnostic features for GCF itself?
Multinucleated giant cells, often lining pseudovascular spaces. These are really characteristic. The background is often hypocellular, maybe myxoid or collagenous, with bland spindle cells, and typically has infiltrative margins in the dermis and subcutis.
And this brings us directly to dermatofibrosarcoma protuberans, DFSP. This is also locally aggressive, but importantly, rarely metastasizing tumor composed of dermal fibroblasts and myofibroblasts. It's really known for its infiltrative growth pattern and a high recurrence rate unless it's widely excised.
Wide margins are key for DFSP management.
DFSP most commonly occurs on the trunk, proximal extremities, and head neck. Often presents initially as a nodular or maybe plaque-like cutaneous mass with slow but persistent growth.
The pathogenesis is really defined by its molecular hallmark, that COL1A1 PDGFB fusion. This usually results from supernumerary ring chromosomes derived from chromosome 17 and 22, or sometimes an unbalanced translocation, T1722. And this isn't just an academic detail, it's a consistent molecular driver. The fusion leads to an autocrine stimulation loop. The tumor cells produce the PDGFB ligand, which then stimulates their own PDGF-beta receptors, driving proliferation.
So they feed themselves,
Pretty
essentially.
much. And critically, this specific pathway involving the PDGF receptor is why targeted therapies like tyrosine kinase inhibitors, such as imatinib, actually work for some of these patients. Especially in unresectable, recurrent, or metastatic cases, it's been a major therapeutic advancement you'll definitely want to be aware of when you sign these out.
It's important to remember that while the COL1A1 PDGFB fusion is classic, maybe 5% or so are negative, and rare cases have alternative fusions like COL6A3 PDGFD. DFSP also has several recognized subtypes, doesn't it?
Yes, including pigmented DFSP, also called Bednar tumor, which has dendritic melanocytic cells scattered within it. There's myxoid DFSP, with prominent myxoid stroma, and the most crucial one for prognosis, fibrosarcomatous DFSP. This represents a morphological progression to a higher grade.
Higher grade means worse prognosis.
Yes, this variant acquires metastatic potential, unlike typical DFSP. Histologically, it shows a more obvious vesicular, often herringbone pattern with increased cellularity, atypia, and mitotic activity. So for your essential diagnostic criteria of classic DFSP, you're looking for that characteristic storiform architecture cell swirling around like a mat. Uniform spindle cell morphology, usually quite monotonous. Diffusely infiltrative growth, often creating that classic honeycomb pattern as it infiltrates the subcutaneous fat, and consistent, strong expression of CD34 immunohistochemically.
And for the fibrosarcomatous change.
Look for loss of the storiform pattern, development of that vesicular or herringbone architecture, increased cellularity, atypia, and importantly, increased mitotic activity. CD34 expression might become focal or lost in these areas.
Prognosis difference.
Huge difference. Ordinary DFSP rarely metastasizes, maybe less than 1%. But fibrosarcomatous progression, seen in about 5% of cases overall, carries a significant, maybe 10–15%, risk of distant metastases, most often to the lungs. This distinction is absolutely critical for patient management and staging.
Okay, next up, inflammatory myofibroblastic tumor, or IMT, often described as the inflammatory spindle cell neoplasm.
Good description. The inflammation can be really prominent.
This is a distinctive, rarely metastasizing neoplasm composed of myofibroblastic and fibroblastic spindle cells, but crucially accompanied by a prominent inflammatory infiltrate. Usually lots of plasma cells, lymphocytes, maybe eosinophils too.
IMT shows a very wide anatomical distribution. It can pop up almost anywhere. Abdominal soft tissues like mesentery or retroperitoneum are common sites. Also lung, mediastinum, head, and neck. Clinically, symptoms are often site-dependent, and up to about 1/3 of patients can actually have a systemic inflammatory syndrome, fever, malaise, weight loss, anemia, thrombocytosis, elevated ESR, or CRP.
Wow, so it can act like an infection or autoimmune disease sometimes.
It can, systemically, which adds to the diagnostic challenge pre-biopsy. The pathogenesis is marked by genetic heterogeneity, but a key finding is that 50–60% of cases, especially in children and young adults, harbor clonal rearrangements involving the ALK gene on chromosome 2p23. This fuses the 3' kinase region of ALK with various upstream partners, like TPM3, TPM4, or CLTC.
Ah, ALK rearrangements, like in lung cancer.
Exactly, same gene, different context, and fusion partners. This ALK genomic rearrangement leads to constitutive activation and overexpression of the ALK kinase domain in the tumor cells, making it a crucial diagnostic marker, and importantly, a potential therapeutic target with ALK inhibitors.
And it's not just ALK, right? There are other possibilities.
Correct. Beyond ALK, ROS1, and NTRK3 gene rearrangements are each found in maybe 5–10% of IMTs. Fusions like TFG ROS1 or ETV6 NTRK3 have been described.
So multiple kinase fusions can drive this tumor type.
Seems so. For immunohistochemistry, ALK protein expression is detectable by IHC in at 50–60% of cases and correlates very well with the presence of an ALK gene rearrangement.
Does the staining pattern matter?
It can. Interestingly, the ALK immunostaining pattern can sometimes vary depending on the specific ALK fusion partner. For example, nuclear membrane staining is typical for RMBP2 ALK fusions, often seen in the more aggressive epithelioid IMT subtype. Cytoplasmic is more common for others. So for your independent sign-out, ALK protein IHC is usually the first step and often sufficient if positive and characteristic. Molecular assays like FESH or sequencing for ALK or other non-ALK fusions like ROS1 or NTRK3 can be used to confirm the diagnosis, or importantly, might be useful in ALK-negative cases to find an alternative targetable driver.
And prognosis.
About 25% of extrapulmonary IMTs tend to recur locally, depends a bit on site and resectability. Distant metastases are rare overall, maybe less than 5%, although that epithelioid IMT subtype, often intra-abdominal and with specific ALK fusions, does behave more aggressively.
So my key is the distinctive histology spindle cells plus prominent inflammation and looking for that crucial ALK rearrangement or other kinase fusions.
That's the core approach.
Finally, in this locally aggressive category, we have myxoinflammatory fibroblastic sarcoma, or MIFS, which I think of as the distal extremity pleomorphic spindle cell because of its characteristic location and, well, sometimes alarming cell morphology.
Yeah, distal extremities, hands, feet, ankles are classic, and the cells can look quite ugly.
It's an infiltrative, locally aggressive fibroblastic neoplasm.
Clinically, these usually present as solitary, often painless masses in those distal sites. Because they're infiltrative, they can sometimes mimic infection or maybe a tenosynovial giant cell tumor or even ganglion cysts radiologically. Histologically, MIS is characterized by these quite pleomorphic fibroblastic cells, often with very large, prominent eosinophilic macronucleoli. They can look quite bizarre. These cells are set in a myxohyaline background, often with a variably prominent inflammatory cell infiltrate mixed in neutrophils, lymphocytes, eosinophils.
Any other characteristic cells?
Yes, the presence of so-called pseudolipoblasts, or virucyte-like cells, large cells with glassy cytoplasm and eccentric nuclei, sometimes with inclusion-like nucleoli, strongly supports the diagnosis. They aren't true lipoblasts, but they resemble them.
Okay.
Prognosis? Local recurrences are common and often repeated, sometimes multiple times, due to the infiltrative nature of the tumor. It's hard to get clear margins. While metastases are rare, usually occurring only after multiple recurrences, the best predictor of a favorable outcome really remains achieving initial complete surgical excision.
It's incredible how these lesions range from being tricky to diagnose because of their inflammatory components like IMT to having very clear genetic drivers like the catenin pathway in desmoid fibromatosis or the kinase fusions in IMT and DFSP. The key takeaway here for your independent sign-out is really to respect their local aggression and understand their recurrence rates. These directly impact patient follow-up schedules and the potential need for re-excisions or adjuvant therapies. Okay, now we need to confront the truly malignant entities, where accurate diagnosis is absolutely paramount for patient survival and guiding systemic treatment planning.
Exactly. Finally, we tackle the clearly malignant end of the fibroblastic myofibroblastic spectrum. While these sarcomas are generally rarer than some of the benign or borderline lesions, recognizing them accurately is, well, paramount for patient prognosis and management. The distinctions here are not just academic, they directly inform potentially life-altering treatment decisions like chemotherapy or radiation.
Let's start with infantile fibrosarcoma, or IFS, which is sometimes described as the pediatric sarcoma with a favorable outlook, despite being malignant.
Relatively favorable, yes, compared to many adult sarcomas. It's a bit of a paradox.
It's a malignant fibroblastic tumor, the most common soft tissue sarcoma in infancy, actually, and it's frequently characterized by a very specific defining genetic event, The ETV6 NTRK3 fusion gene. It's locally aggressive, often rapidly growing, but importantly, only rarely metastasizes, which is why the outlook is better.
Clinically, IFS typically manifests as a localized, rapidly enlarging, painless mass or swelling, sometimes an exophytic nodule. About a third of cases are present right at birth, congenital, and maybe 14% are even detected on prenatal ultrasound. They can sometimes ulcerate the skin or even resemble vascular tumors clinically. Intratumoral hemorrhage can occasionally cause significant anemia or even shock in infants.
And histologic.
It's typically a cellular spindle cell tumor. Sometimes more primitive ovoid or round cells are mixed in, often arranged in a fascicular or classic herringbone pattern. Characteristically, you see these dilated, branching, staghorn-shaped blood vessels, and often a mixed inflammatory infiltrate.
Okay. And the pathogenesis is all about that fusion.
Primarily, yes, driven by oncogenic activation of kinase signaling. The canonical fusion in most cases is that ETV6 NTRK3 fusion, resulting from a translocation T1215 P13Q25. This is your definitive diagnostic marker. If you find this fusion in the right clinical and morphological context, it's IFS.
Are there alternatives?
Yes, though much rarer. A subset can have other kinase fusions involving NTRK1, NTRK2, BRIFF, or MET instead of NTRK3, but the ETV6 NTRK3 is the classic one.
Okay, so essential diagnostic criteria. Mostly infants under 2, cellular spindle primitive cell tumor, maybe fascicular herringbone pattern, staghorn vessels.
And ideally confirmation of the ETV6 NTRK3 fusion or one of the rarer alternative rearrangements involving NTRK1, BRIFF, MET.
And the prognosis reflects that favorable outlook.
Generally, yes. Locally aggressive, certainly, but relatively infrequent metastases. Overall outcome is quite good for a sarcoma, with 10-year survival around 90%. Local recurrence rates are significant, though, maybe 25–40%, highly associated with incomplete resection initially. Metastasis rate is low, maybe 8–15%.
Then treatment.
Surgery is primary. But here's the game changer, similar to IMT. The advent of targeted tyrosine kinase inhibitors, specifically TRK inhibitors like laratinib or entrectinib, for these NTRK-fused tumors. This can dramatically alter the prognosis and clinical management, especially in unresectable, recurrent, or metastatic cases. It allows for less morbid initial surgery sometimes, too, making that molecular diagnosis critically important for therapy.
Okay. Next, let's turn to adult fibrosarcoma, which you basically described earlier as now being the diagnosis of exclusion.
That's exactly right. It's become exceedingly rare in modern practice.
Once considered a common diagnosis, advances in IHC and molecular pathology have allowed us to reclassify most historical fibrosarcomas into more specific entities like MPNST, synovial sarcoma, low-grade fibromyxoid sarcoma, etc.
Precisely. It's strictly defined today. True adult fibrosarcoma probably accounts for less than 1% of all adult soft tissue sarcomas. It typically affects middle-aged and older adults, maybe median age around 50. Slightly more common in men. Some might arise in the setting of previous irradiation or rarely associated with implanted foreign material, but most are sporadic with unknown cause. Pathogenesis is less clear than for many other sarcomas, partly because it's so rare now. Older studies reported complex chromosomal abnormalities. A recent report found an STRN3-NTRK3 fusion in one case, hinting at a possible link to other NTRK-rearranged tumors, but that's very preliminary.
So for me signing out, how do I diagnose it if it's exclusion?
You need to see a relatively monomorphic population of spindle cells, maybe with only moderate nuclear pleomorphism at most, arranged in a fascicular herringbone architecture, usually with variable collagen production. But the most critical point, as you said, is that it becomes an immunohistochemical and molecular genetic diagnosis of exclusion. You have to rule out everything else. It could be synovial sarcoma, MPNST, leiomyosarcoma, solitary fibrous tumor, LGFMS, undifferentiated pleomorphic sarcoma. The list goes on.
So lots of IHC and potentially molecular testing needed just to rule things out.
Exactly. You basically arrive here when it's clearly a spindle cell sarcoma, but it doesn't fit the specific criteria or markers for any other defined type.
And the prognosis, if you do end up calling it that.
Generally poor. More than 80% behave as high-grade sarcomas. Overall survival might be less than 70% at 2 years, maybe under 55% at 5 years. It metastasizes, usually to lungs and bone. Behavior likely relates to grade, size, and depth. Local recurrence depends on surgical margins.
Okay. Finally, let's talk about low-grade fibromyxoid sarcoma, LGFMS, and its close relative, sclerosing epithelioid fibrosarcoma, SEF. These are intimately related and fall into what's sometimes called the FUF3L family of tumors because of their characteristic gene fusions.
Right. Let's start with low-grade fibromyxoid sarcoma, or LGFMS. This is a malignant fibroblastic neoplasm that can be deceptively bland looking into the microscope. That's why the low-grade name can be tricky. It's characterized by alternating areas of collagenous fibrostroma and more myxoid areas. The cells themselves are relatively bland spindle cells, often arranged in a swirling or whorling pattern, sometimes short fascicles, and typically you see arcades of small, thin-walled blood vessels.
Okay, alternating fibrous myxoid, bland cells, whorls, arcading vessels. What makes it distinct?
What makes these tumors diagnostically firm is their consistent presence of specific gene fusions, usually FUS-free3L2, or less commonly FUS-free3L1.
And for my independent practice, is there a good IHC marker?
Yes, absolutely. MEC4 expression by IHC is strong and diffuse in nearly all cases of LGFMS. It's a highly sensitive and pretty specific marker. So if MEC4 is positive in the right morphologic context, that's very strong support. If MEC4 is negative or maybe unavailable, then identifying the FUS-Rep3L2 fusion or its variants by molecular testing really supports the diagnosis.
Got it. MUC4 is key. Now, the prognosis, you said the low-grade name is
Tricky.
extremely tricky because while it shows relatively low rates of recurrence and metastasis in the first 5 years after diagnosis, maybe 10% recurrence, 5% mets, these rates become much, much higher with long-term follow-up. This is critical. This is a crucial point for you to counsel clinicians on. Large studies with long follow-up show recurrence rates eventually reaching over 60%, metastases in over 40%, and death from disease in over 40% of patients. Metastases can occur as long as 45 years after the primary excision ever. Median time is maybe 5 years, but the risk persists for decades. Median survival might be around 15 years.
Wow. So low grade definitely does not mean no risk here, especially long term. Absolutely not. It implies indolent but relentless potential. Most common metastatic sites are lung and pleura. Interestingly, histological features generally don't correlate well with behavior in classic LGFMS. But tumors that show areas resembling sclerosing epithelioid fibrosarcoma, or maybe areas with round cell morphology, tend to pursue a more aggressive clinical course.
Okay, that brings us directly to sclerosing epithelioid fibrosarcoma, or CEF.
Right. CEF is a rare malignant fibroblastic neoplasm. It looks quite different from classic LGFMS, at least in its pure form. It's characterized by epithelioid-looking fibroblasts arranged in cords, nests, or strands, embedded in a really dense sclerotic hyalinized stroma. It looks almost like scar tissue with cells trapped in it. And importantly, a subset of CEFs are related morphologically and molecularly to LGFMS, solidifying their familial connection. You can even get a hybrid tumor showing features of both.
Okay, and the pathogenesis, gene fusions again.
Yes, but typically different ones than classic LGFMS. The most frequent fusion in CEF, found in over 60%, is UWSR1-CREB3L1. Rare variant fusions exist, sometimes involving FUS instead of UWSR1 or other CPREB family members. Interestingly, most hybrid CEF-FL-GFMS tumors actually display the FUS-CREB3L2 chimera, the same one found in most pure LGFMS.
So the genetics overlap but also show some distinctions.
Correct. And pure CEF tends to have more complex genomic profiles than LGFMS, often with additional deletions or losses.
IHC for CEF, MEC4 again.
Yes, MEC4 is present and usually strong and diffuse in about 80–90% of CEF cases as well, so it's useful for both. CEF can also express EMA and SMA in about 40% of cases. Keratins are typically negative, which is helpful in distinguishing it from metastatic carcinoma, which it can resemble due to the epithelioid cells and nests.
Molecular testing needed.
Can be confirmatory, looking for the EWSR1, CREB3L1, or other rearrangements, but often not strictly needed if the morphology is characteristic and MEC4 is positive. So the LGFMS and CEF relationship is really a perfect example of how morphology, IHC like MEC4, and molecular testing for the specific fusions all converge to define these entities. And that long latency to recurrence metastasis, particularly in LGFMS, is just such a powerful reminder that low grade doesn't mean benign, especially when it comes to long-term follow-up. This is absolutely crucial information for you to convey to clinicians managing these patients. Hashtag outro.
Wow. We have really covered a vast landscape of fibroblastic and myofibroblastic tumors today, specifically geared for you as you prepare for that independent sign-out role. From the, self-limiting nodular fasciitis with its transient neoplasia concept and the USP6 rearrangement, to the locally aggressive desmoid fibromatosis driven by those critical nuclear and pathway mutations, and then onto the true sarcomas like infantile fibrosarcoma with its ETV6 NTRK3 fusion and that surprisingly favorable outlook, and finally the deceptively named low-grade fibromucoid sarcoma with its FUS Calabriel fusions and those really critical long-term follow-up implications. It's a lot to keep straight.
It absolutely highlights the essential and sometimes challenging role you play in bone and soft tissue pathology. Remember, each of these entities, while they might all initially appear as just spindle cell lesions under the microscope, carries unique diagnostic clues. Clues spread across the clinical presentation, the specific histology, the immunohistochemistry, and, well, increasingly, the molecular genetics. Knowing which gene fusions to look for, which IHC markers are critical, and what the expected clinical course and recurrence risk is, that's what will empower your independent sign-out process. And ultimately, that knowledge guides optimal patient care.
Right. This deep dive wasn't just about, memorizing lists of facts. It was really about equipping you with the framework, the way to think about approaching these cases confidently. Think about how understanding these patterns, the histology, the IHC, the molecular drivers helps you narrow down your differentials, guides your ancillary testing strategy, and importantly, allows you to communicate critical prognostic information effectively to your clinical colleagues, your surgeons, your oncologists.
Exactly. You're not just identifying a tumor type. You're informing crucial patient care decisions that can have really long-lasting impacts on someone's life.
So as you prepare to sign out independently and you're facing that next challenging spindle cell case, here's maybe a final provocative thought for you to mull over. Given the absolutely increasing role of molecular findings in defining these tumors and also in informing targeted therapies, how might the landscape of diagnosis and treatment for soft tissue sarcomas continue to evolve in, say, the next 5, 10 years? What might change about what we consider essential diagnostic criteria in routine practice? Will IHC for specific fusion proteins become the new frontline test, maybe? Or will comprehensive genomic sequencing just become standard for almost every spindle cell sarcoma?
That's an excellent question to ponder as you embark on your career. It's clear that staying updated with these molecular insights, understanding their implications, that's going to be absolutely key to your continued success and providing the best patient care in this rapidly evolving field.
That's it for this step dive. We really hope this exploration has been as insightful for you preparing for sign out as it was for us discussing it. Until next time, keep digging for those nuggets of knowledge.